This lecture will cover the introduction to child and adolescent psychiatry. Now, childhood and adolescence is a time of significant growth and development. Children and teenagers have to juggle lots of different roles and relationships that are changing as they age. Now, childhood and adolescence is a time of significant vulnerability where people have less agency themselves and have to rely on others to get their needs met. So they have to rely on their parents or other institutions or governmental agencies. Any disorder in childhood, whether it be a mental disorder or a physical disorder, can exert lasting effects beyond the actual condition. And this is because any kind of dysfunction during this time will impact other areas of development and cause more dysfunction. So common complications of childhood onset disorders include things like progressive learning delays, school failure, low self-esteem, demoralization, rejection by peers, and impaired relationships with family members. There can be a lot of frustration within family systems of children who have psychiatric or behavioral issues, so those children do have a higher risk of being victims or survivors of child abuse. About 10 to 20% of children worldwide are affected by mental health problems, and those most at risk are those who face intense stressors, who have a loss of a caregiver, suffer from chronic illness, or have a family history of psychiatric issues. Psychiatric conditions are often detected as the child grows and faces new developmental challenges. As more demands are placed on a child, it may exceed the child's ability, and the child may have increased vulnerability to developing illness at that time. Now, the effects of early developmental deficits may be compensated by future opportunities or may be exacerbated by additional barrier. So things like access to care, access to services within a school district, having a good support system, all of these can impact the trajectory of a child's life, especially if they have mental health issues. And another barrier that's important here is just having a lack of overall trained child and adolescent psychiatrists nationwide. So these are the specific childhood onset psychiatric disorders that we'll cover in this lecture series. It's also important to remember that in addition to those childhood onset disorders, the ones that we'll learn shortly, children and adolescents can also be diagnosed with these psychiatric disorders that can also present in adults. So pretty much everything we've learned about before. One thing that I think is important to note is with major depressive disorder, children might have irritable or angry mood instead of showing a depressed mood. So that is one important distinction that you should remember. So this table goes over the 10 leading causes of death by age group in the United States. We've already talked about how suicide is the 10th most common cause of death in the United States, but when we look at children and adolescents, it's actually the number 2 cause of death for people between the ages of 10 and 24. And number 1 is unintentional injury, some of which are likely also suicides, but just have not been classified as such. The subgroups of children and adolescents that are most at risk of suicide are LGBTQ youth, homeless youth, youth that use substances, and then incarcerated youth. And a lot of these are interrelated. LGBTQ youth are disproportionately represented in the homeless population. Those that are homeless or LGBTQ are more likely to use substances. And then those that are homeless are also more likely to rely on survival crime and then subsequently become incarcerated. The child and adolescent psychiatric evaluation is a little different than what you would perform with adults. In general, parents tend to be more reliable than their children until children reach the age of 10. Parents are usually better at providing factual time-related information and information about externalizing symptoms like behavioral issues at home. Children are usually hesitant in reporting behaviors that get them into trouble. Children, though, are able to report far more information about internal symptoms like anxiety and depressive symptoms that their parents might not notice. It's always important to review additional sources of information, such as from schools or teachers, because the view from the parents is usually not complete. And then you also want to interview the child and parents separately as well as together. When you're interviewing them separately, you should let the parents and the child know that the physician-patient interactions are confidential. However, you may have to break that confidentiality if you feel that the child is in danger of harming themselves or others. Now, it's important to evaluate the family functioning as a whole unit, and you want to see how family members interact with each other during the session. Mothers should be asked about whether they had any complications during pregnancy or exposure to substances or toxins during pregnancy. And then parents should also be asked about their child's developmental milestone history, any family psychiatric history, and then parenting techniques that they're using. Now, these are some of the developmental milestones that pediatricians will follow up on with children during their regular visits. The 4 categories of development are gross motor, visual motor, language, and social adaptive. And the language and social adaptive developmental milestones are particularly important in recognizing any psychiatric conditions that might be arising. I'm not expecting you to memorize all of these, but I do think it's important to know the ones that are bolded and highlighted, because they might help you differentiate what is normal versus not normal when we're trying to recognize psychiatric conditions in children. For example, you can see from this table that separation anxiety is considered normal childhood behavior around 1 year of age, but it might not be considered normal later on in life, around like 4 to 5 years of age. Similarly, if you're seeing a child only engaged in parallel play, meaning playing next to children but not necessarily playing with other children, that might be considered normal behavior at around 2 years of age. But at 4 years of age, you might be expecting children to interact with other children. And if they're still not doing that, that might be something to keep a close eye on. Now, we briefly discussed how during the psychiatric evaluation for children and adolescents, you want to see how the family interacts in the session. And this is because the environment, parenting, and social modeling can also play a role in childhood onset psychiatric disorders, especially the anxiety disorders and behavioral disorders that we see in children. There are a couple of types of learning that are important to know. The first is classical conditioning, and the most popular example of this that you may have heard of before is how Pavlov trained his dogs with classical conditioning. So what he did was he had an unconditioned response to an unconditioned stimulus. So dogs would salivate naturally when they sensed the odor of food, right? So the odor of food would be the unconditioned stimulus, and the salivation is the unconditioned response. So he added another stimulus, such as a bell ringing, whenever he presented the odor of food to the dogs. So eventually, the bell ringing would cause salivation, and the bell ringing would be the conditioned stimulus, which would cause a conditioned response, such as salivation, even in the absence of the odor of food. Another type of learning is operant conditioning, and this is when you want to increase or decrease the frequency of behaviors in a person. So negative reinforcement is when you increase the frequency of a particular behavior by removing an aversive stimulus when that person performs that behavior. Positive reinforcement is increasing a behavior by rewarding it. So someone is more likely to repeat that behavior if they've been rewarded for it in the past. Punishment is when you discourage a behavior. So you're trying to decrease a particular behavior by introducing an aversive stimulus if that behavior is formed. And then extinction is when a behavior is eliminated by no reinforcement. So this is similar to maybe ignoring a child's temper tantrums, and eventually when that child does not get the attention that they were hoping for with the temper tantrum, that behavior becomes extinguished. Now, something else that's important to know is the concept of modeling. And this is when a child behaves in a manner similar to that of someone they admire. So this is a picture from Albert Bandura's Bobo doll experiments, where he had this blow-up doll, and had children watch what adults would do in the room with the blow-up doll. And when adults were violent towards that blow-up doll, the children would also become show more violent behaviors towards that doll.